Welcome, everybody. We'd like to welcome you, all of our viewers and listeners, to another Road to Wellness webinar. I'm Kathy Olewski, the host of Road to Wellness educational webinar series for the Vasculitis Foundation. I'm a patient living with vasculitis, just like many of you. I was diagnosed with ANCA-MPA in 2008. I was in treatment for 6 years, and I'm extremely grateful to have been in remission off treatment for 8 years. And now I hope to help the Vasculitis Foundation bring awareness to the many diseases of vasculitis. So today our topic is Behcet's vasculitis, and we have a few guests with us today that I'd like to introduce. First of all, Dr. Andrew Suclich is the Chief of Rheumatology at Ascension St. John Medical Center in Detroit, and he's an Assistant Clinical Professor at Oakland University William Beaumont School of Medicine. Dr. Suclich is a rheumatologist in private practice at Shores Rheumatology, St. Clair Shores, Michigan, and is a fellow of the American College of Rheumatology and board member of the American Behcet's Foundation. We also have two patients with us today to give us their perspective. First, we have Alan Strum. He's with us from Sydney, Australia, and it took 28 years for Alan to get his diagnosis in 2011. It was identified as continuously cycling neuro-Behcet's disease. He recently started to experience the beginning of remission. Alan has started to write a book about his lived experience with Behcet's and plans on becoming an inspirational speaker. He worked in HIV/AIDS for 17 years as an advocate, translating complex medical information into easy to understand English through direct client support and writing in education programs. He's also provided support to the Behcet's group on Facebook. And Beth Howe is another patient joining us from Michigan. It took about 20 years of doctor's appointments, labs, and hit or miss guessing to finally be diagnosed with Behcet's disease for Beth. She's become an advocate for our community to help others be diagnosed quicker and help provide education, empowerment, and support. Beth has done webinars, written articles, radio interviews, and has spoken at the Vasculitis Foundation Symposium in Chicago. Beth also runs the largest support forum for Behcet's in the world. Welcome, everybody. We appreciate you being here today.
Thank you.
And I think we'll begin today by learning a bit about Behcet's, which is probably something we all need. So I'll turn it over at this time to Dr. Suclich.
Kathy, thank you very much for the warm introduction. I really am privileged to have Alan and Beth with me, our patients, to keep me honest in this discussion of Behcet's disease. And what makes Michigan a little bit unique in the setting of Behcet's is that we have several different populations there in our state that are at risk. First and foremost, we have the largest Arab population outside the Middle East. We have an Israeli population here, a Greek population here. We have many patients in the auto industry from Japan and Korea. And so Behcet's is kind of a situation where I stumbled into because I wasn't really trained by it in my fellowship, because it was thought to be a quote unquote rare disease. And I've got an appreciation of the diversity of the disease and the people that are associated with it. The second thing we're talking about today is vasculitis. And we think, why is Behcet's disease talked about? Because vasculitis is the hallmark of Behcet's. It's a vasculopathy. And it runs the spectrum between this very small veins all the way up to the very small arteries. So it's really a pan-vasculitis that's seen, but it manifests differently in a variety of different types of patients. If we talk about a Behcet's disease as a diagnosis, we think about it as a chronic relapsing inflammatory disease. It's not an autoimmune disease in a setting that we don't have autoantibodies. And that's one of the reasons why it's difficult to diagnose, because we have no markers for it. But it's considered a rare disease, and I would take umbrage with that, because when you're looking at a rare disease, you look at numbers, and you think about it, the way I think about it, when I'm here in Michigan, I go to University of Michigan football game, there's 100,000 people in the stands. I think to myself, there may be 5 Behcet's patients in that whole population watching this game. So in the United States, the average is between 5.2 per 100,000. But these data tend to be on the older side in 2016. And if you run over to Europe, and particularly look at Iran and Turkey, the numbers there are 400 per 100,000. So it's much more common in different areas. But because we're seeing migration happening to the United States and immigration, you're seeing the fact that this is going to increase over time. It's called the Silk Road disease because if you follow Europe all the way from France and Spain across the Middle East and in the Far East, there seems to be a band of patients that are more prone to this disease. And that's why they call it the Silk Road disease, because of trading that happened over 1,000 years ago, and it still is present in these patients. The typical onset of Behcet's disease is in 20 to 40 years of age. The problem is, as we'll talk about, is it doesn't come all at once. And so it evolves. And so the problem that we face with Behcet's disease, it's an evolving and a relapsing disease. So it's not always present when you come see the doctor. So there are many challenges in the beginning to, number one, recognize this disease because we haven't been trained to recognize it. Number two, because of its relapsing and remitting nature. If we look at Behcet's disease, and this is the typical stylized presentation that we give to our fellows with some differences. Number one, they say Behcet's disease is a disease of males. Well, that's not necessarily true. The ones we see, the most commonly ones in the Middle East are males, and they tend to have the more severe disease. Nevertheless, we see many more women with this disease. Notice it says age under 25. They have more severe disease. That's true. But again, I see much more women in my practice here in the United States. Usually diagnosis between the second and third decades. They have recurrent symptoms and they're evolving. So sometimes that diagnosis may take 5 to 10 years because the initial presentation may not be diagnostic. You have to wait until other areas of the body become more apparent to the clinician to make this diagnosis. And even though I say that in 5 to 10 years, once you make the diagnosis, the frequency does decrease. That's in general. There are patients out that the frequency does not decrease and they may get severe. So see here a timeline. Patients universally have what they call oral ulcers, and we'll talk about what those ulcers are. Then they kind of develop a spectrum of disease. They can develop joint disease, skin disease, arthritis, uveitis, which is the most common eye disease associated with it, all the way to a neurological manifestation. So you see this is an evolving disease, but it's not going to happen in everybody. And that's really where the challenge is, especially when a patient is sitting across from me saying, what's going to happen to me, doctor, when I've been diagnosed with this disease? So what's the cause of Behcet's disease? As most of the immunological disease that I deal with, it's unknown. We suspect there may be something in the environment, and that's why we saw the Silk Road. It may be infectious in nature. They have had associations and studies looking at streptococcus. They looked at Epstein-Barr. They looked at herpes simplex, as well as environmental trigger. And then there's genetic predisposition. So you may say, well, I don't have anybody in my family that has Behcet's disease, but they may carry the genes that may put you at risk. And there's certainly some genes that we notice that are more common in patients. That's the HLA-B51. It's not a diagnostic marker, but at least we see that with this gene, it's more commonly associated with Behcet's disease and a variety of other types of genes as well. So you have the genetically predisposed person, something in environment. You have the immune response, and typically our immune response is targeted toward foreign bodies and infections. Well, in Behcet's disease, it's targeting your own body. And so as a result, you have this uncontrolled inflammatory response that happens for a period of time and then shuts off and then recurs again. And there you see the production of inflammation, the side of what we call cytokines, which are basically chemical messengers that make cells act inappropriately in a chronic setting, appropriately if there's an infection. But remember, with Behcet's disease, where there is no infection that we know of, it's really an environmental trigger that continues on with inflammatory type cascade. And then ultimately develops inflammation as a result of this. And that's really what causes the damage, anywhere from mouth ulcers to involvement in the blood vessels. So this is where the challenge occurs is, again, witnessing what happens with these patients. If we look at the hallmarks, and this is about 98% of patients have this, are the oral ulcers. And if you look at the oral ulcers, there are several types of them. They could be one of the major ones to your far left there. These are very large, very painful ulcers that occur, and they can cause scarring. Then you have minor ulcers that occurs. And the trick is, and I always tell my residents that if you look at these ulcers, they're going to happen in the mucosal surface. They're not going to happen on the skin surfaces, or we call the epithelialized surfaces. So you see these ulcers are happening more on the mucosal layer and not at the epithelium. And so you can have minor ulcers, could be just as painful. They can last sometimes between 7 to 14 days. I've had people last a month. And they're often misdiagnosed because there's nothing else associated with them. So you go see a doctor with either an aphthous ulcer, they're going to treat you for something else, like herpes simplex. As you see on the far right, they have herpetiform ulcers as well. And they can also involve the pharynx. So many of my patients can report difficulty in swallowing simply because they have pharyngeal ulcers. So you see these relapsing areas of sometimes up to 9 to 14 times per year can be problematic. And so that's really the first usually signs I see. Sometimes I see genital ulcers about 2% of the time. And it's a very sensitive issue to many patients who may not present with oral ulcers. They may present with genital ulcers as a presenting sign. Here's the tragedy of Behcet's disease. On average, we're looking at a diagnosis between 5 to 8 years from symptom onset. Imagine any other disease that you see in practice, that you take 5 years to make a diagnosis. This is terribly frustrating for patients. It's frustrating for clinicians. And again, if it's not recognized or thought about, people will tend to miss it. And so as a result, we usually look for a second manifestation associated with the oral ulcers. We finally say, oh, this may be Behcet's. If we look at those manifestations, you see in this picture, it kind of depicts what the Behcet's patients may suffer from. You see the oral ulcers 98% of the time, genital ulcers about 80% of the time, ICI involvement about 50% of the time. This presents as uveitis, a very painful type presentation. And a lot of my referrals come from actually ophthalmologists when they see them, because they see the eye disease and they ask a history of ulcers in the mouth. And many patients can't make that connection. They say, well, what does that have to do with my eye disease? And so again, that should trigger a response to a clinician and say, oh, maybe this is Behcet's. If we look at the other types, skin lesions are very common, but they're very subtle. They can present as acne or folliculitis or a condition called erythema nodosum. So they're very subtle in my patients that we pick up. I have a 40-year-old patient with acne. You have to start thinking this is a little bit strange or different. And there's joint involvement. It can be relapsing and remitting. I've seen people that presented as looking like rheumatoid arthritis and so forth. They present with joint involvement in addition to their mouth ulcers. And then there are more the devastating complications. We see the vascular involvement, which can involve the venous side in terms of blood clots. It can go to lung, and it can also involve neurological, which is one of the most aggressive part of Behcet's disease. We have to be careful in this country because it's so easy to say you've got recurrent mouth ulcers, you have Behcet's. There are many other diseases we don't have time to go through that can present with mouth ulcers. And so we as rheumatologists or immune specialists have to think about predominantly what else can be going on. Like, for instance, I see many people with GI involvement with Behcet's disease, but you also have to think about inflammatory bowel disease, because patients with inflammatory bowel disease can have mouth ulcers, they can have skin lesions, and they can have GI complications. So again, it's a tricky diagnosis. We have to think about differential with our patients to think about what other diseases that can mimic Behcet's and therefore exclude them before we make a diagnosis. How do we make a diagnosis? Again, it's based on clinical grounds. Okay, we have no laboratory markers. So this is called the ISG, or National Study Group. It was actually made in 1990. So obviously it's 30 years old, but it gives you an idea that patients have to have the recurrent ulcers at least observed by a doctor on 3 times. And then you have to look at other factors. Do they have genital ulcers? Do they have the skin lesions? Do they have eye lesions? And then they have a test called pathergy. Now, this is confusing to many Behcet's patients because they say, may I have this? What pathergy is when you take a needle and you poke it through the skin, there develops a pustule. I always ask my patient, what happens when you have your blood drawn? And they'll tell me, sometimes when they draw my blood, I get this like pustule. It looks like an infection. That's pathergy. The problem with pathergy is it's not always present. It's more present I see in more Middle Eastern Behcet's, more I see with Turkey than I see here in the United States. So even though we try to do the pathergy test, it's not always positive. The vast majority is going to be negative. And the other problem is sometimes a positive pathergy test may result in other diseases. So we have to be a little bit careful that there's no one diagnostic test, and that's what leads to the frustration. So how do we treat our patients? First, we have to make a diagnosis, and they got to get to my office. So I see people from ENT, I see people from ophthalmology, I see people from dermatology, even see people from GI. So most of the time, it's not a direct line from me to my office. It actually has to go through some specialists. Once you make the diagnosis, you have to assess risk. Okay, what's going on with the patient? Is it the mouth ulcers that are occurring, which are problematic and very painful? Or do I have other diseases that are progressing? So I have to follow my patients very closely, at least for the first 5 to 10 years, to see if they evolve into anything else. So I have to think about organ involvement. eye involvement. So everyone gets an eye exam at least twice a year. I also make sure that we do a complete physical exam at least once a year. I do get some laboratory monitors in terms of CBC, inflammatory markers, and I see these patients very often to make sure that they're not evolving into anything beyond what's currently, which is typically we see as the skin and mouth ulcers. Then you look at disease severity. Some may require immune suppression. We have to use very sophisticated medications such as steroids and also disease-modifying drugs. And there are very few drugs that are approved for Behcet's. There's only one that's approved for mouth ulcers, that's apremilast. So we kind of borrow medications from other types of diseases in order for treatment. And then we have to look at the patient type. We're dealing with a young woman that may get pregnant. We have to think about that. We think comorbidities. What if you're diabetes? Can I use steroids? What if I have other medical problems? So we have to be thinking about patient types and who we give these products to. So it's not always a straight line of writing a prescription and giving it to our patient. And I got to think about patient preference too. How are they debilitated by this disease? I have an executive who is debilitated by mouth ulcers. They can't speak. I'm going to be very aggressive with that patient because they need that kind of therapy so they can work. So we have to think about patient preference, what they're willing to tolerate, and what works for them as well. The other factor you think about is quality of life. And we as doctors, when we see our patients, I try to incorporate that in my practice. Think about their pain, so what they're going through. Particularly, can they sleep at night? Are they able to talk? Are they able to eat? Problems with mobility, if they have GI involvement or joint involvement. Fatigue is a big problem because you can imagine if you're in pain, you don't usually sleep at night. And that is a huge issue, especially if you have an inflammatory burden. And then, of course, the sleep disturbance is a very big problem of mine. And then trying to go back to activities of daily living. Imagine people with intimacy issues with regards to genital ulcers. These are very difficult things that are not always measurable by laboratory studies, but yet very important in terms of our patients with Behcet's. And with that, why don't we turn it over to the group, and I'll be happy to engage in this, wonderful group of patients that we can discuss about the issues of management of Behcet's.
Well, thank you so much for that great presentation, Dr. Suclich. It's meant to help all of us understand what these various patients are going through, and I think it did just that. I think at this point, what we would like to do is have both Alan and Beth share a little bit of their story of how they got diagnosed and what their current situation is, and maybe you can talk with them about their experiences. And I think we'll start with Alan, if that's okay. Alan, if you'll unmute, I think we'll let you begin your story.
Sure. No, that'd be lovely. Thank you, Dr. Suclich. That was a really wonderful presentation, and I'm just a little sorry that you're all the way over there and I'm all the way over here. Otherwise, I'd be knocking at your door. So, as Kathy was saying, my name is Alan. I live in Sydney. I was diagnosed with Behcet's disease back in 2011, but it was a long, long journey for me to actually get there. So it wasn't until we were actually suspicious that my general practitioner and I were suspicious that it was Behcet's or Behcet's disease, that I had to actually start thinking back about all of my symptoms over the years. And that's when we were able to identify, hey, look, I had most likely erythema nodosa when I was 20 years old. And that was, as a 20-year-old, it was a very, very difficult thing to manage. It was incredibly painful. I saw my general practitioner at that point in time, and they took one look at it and said, that looks awful. Let's give you a steroid shot. And it got rid of it, within a couple of days, and was the last time I saw of it. The next year, I got mononucleosis, and I ended up with extreme fatigue for about 8 years. And as was discussed up there, maybe mononucleosis or Epstein-Barr virus could be a potential trigger. Maybe it added into what was going on with my disease. Through my 20s, other than the fatigue, I tended to be all right, other than the occasional sort of cut that I had in my mouth or a scratch. When I hit 29, I started to get my very first genital ulcers. And of course, I went racing to my doctor and went, doctor, look what's going on. What is it? And the doctor went, oh, well, you have herpes. And I'd studied sexual health diseases, and it was sort of like, it's not herpes. And he just went, you're anxious. And I went, okay, I'm not going to argue with this. So, sometimes it's time to step back and just take account of what's going on. when I hit my early 30s, I started to have some neurological issues where I could just feel something wasn't right in my brain. And I couldn't tell you what that was. There were no words to describe what it was that I was feeling. So I couldn't actually go to a doctor and say, "Doctor, there's something wrong with me," because I didn't know what to actually say to the doctor. And, that's somebody coming from a medical information background. When I hit as I discovered, with every job that I went up that had increased stress, I became more sick. And so there was definitely a connection between the stress and the fatigue associated with that and the jobs. And so when I hit my mid-30s, I'd moved into a semi-executive position. And at that point in time, I started to get extreme anxiety, but for no reason whatsoever. There was nothing that was making me anxious. It was just the fight or flight section, fight or flight section that was out of kilter. And that ended up with me being placed onto anti-anxieties because I ended up with a huge panic attack on a 2-hour plane trip. So the psychiatrist wasn't particularly happy with me. So that got put down to anxiety as opposed to, is there a CNS issue taking place? Further on from that, in my 30s, I started to have issues with the bladder. The bladder wasn't emptying properly, so I don't know what that is. Dr. Suclich, you might want to talk about that later. A bit of sexual dysfunction was starting to occur. And extreme fatigue was also really starting to set in. So I was having to manage my fatigue. Then moving forward into my 40s, the neurological issues, the GI issues, or pretty much every issue except the eye issue, other than visual acuity, was coming in for me. So sore belly, sore joints, not being able to think properly. At one point in time, I turned up at work. I wasn't able to make a decision. I couldn't write an email that anybody could understand except myself. And then if they brought it back to me, it was gobbledygook. Nobody could understand what I was saying when I was getting up and giving major presentations because my words were coming out backwards. And I was so unbalanced that I was bumping into walls. And at that point in time, I was having constant headaches that just were not going away. And I could feel this incredible pressure building up in my brain. Now, the only one thing that worked in my favor at this point in time was the genital ulcers had become so bad that my general practitioner I was seeing, he took a swab one day and he said, "I'm really sick and tired of seeing this." He took a swab for herpes and did the regular STI tests and sent me home with an enormous amount of herpes medication and a steroid cream. And he said, "Go and use both of these, chuck everything at it." But I separated out the herpes drugs from the steroid cream. The herpes drugs did absolutely nothing. The steroid cream got rid of it within about 2 hours. 90% of it was gone. And by the end of the day, it was pretty much all gone. And that was a 2-inch wide sore that had closed over within nearly 2 hours. So I emailed the doctor and he went, "Well, that has to be Behcet syndrome. Good luck with that." He was joking. He didn't think I was serious. So I looked up Behcet syndrome at that time, and there was not just Behcet syndrome, but neuro-Behcet syndrome, or neuro-Behcet's disease. So I copied that out. I took that to him and he went, "Oh my God, this is actually what you have. You are incredibly sick. All this time I thought you had, mental health disorders, that you had major depression, that you were an anxious patient, that you had hypochondriasis. I was wrong. You were actually really, really sick." And from that point forward, we tried to get the specialist diagnosis, which again was another bridge. So the first doctor I saw basically said, "Hey, look, you're too white. You can't have this disease." And I just sort of slammed the door and ran. I couldn't take that. And I do have Middle Eastern Israeli background. So, there was no asking about family history, which is very important. But when I was absolutely desperate, incredibly lucky that a doctor from the US who was a Behcet specialist was coming to Australia. I sent him an email saying I was desperate for help. He was going to see me literally the next week when he was going to a rheumatology conference. And he just sat me down and he said, "You definitely have neuro-Behcet's disease." And from there on, my treatments then started to improve and also my doctors believed me. So my first treatments then were, the first treatment that I was on for 5 years didn't actually cross the blood-brain barrier, which I think Dr. Suclich, you might want to talk about a little bit later on if we have that opportunity. And so 5 years down the track, I was finally placed onto another treatment which did cross the blood-brain barrier, mycophenolate, which I'm currently on now. And I'm doing incredibly well on that. And I have now entered into what feels like remission. I'm now actually active. I've got a lot more energy. I'm doing things. I'm exercising 3 times a week. I'm reclaiming my body, is what I call it. The body has been damaged from 10 to 12 years worth of inactivity due to the disease being so severe in the last years since diagnosis. But now I'm claiming it back. And that's where we are today.
Alan, thank you so much for sharing all that. Dr. Suclich, I think before we move to Beth, I think maybe we'll ask you to answer some of Alan's really great questions, if you don't mind.
Well, in retrospect, we're all heroes. If I listen to Alan's story, I say, well, of course, that's Behcet's. The problem is, it was an evolving story, and no one put the pieces together. And I'm trying to humble myself. We all make mistakes in medicine. The question is, we learn from them. And so in your first experience with herpes, and you think about it in Australia, and if the clinician is not familiar with Behcet's, he'll probably treat you for herpes. But if you keep coming back, it's a problem. You say, what's going on with this patient? Erythema nodosum is not something that's unusual. I mean, when you said back in the 20s, an erythema nodosum can be presented by a whole host of things, but you should heighten your experience and say, wait a minute, I had erythema nodosum. In this country, we would be thinking of sarcoidosis or Crohn's disease, possibly a medication. But if you don't have those, what else could it be? And then you saw this evolution that was taking place, in your life. You have to kind of start putting the pieces together. And that's the frustrating part. With high blood pressure, you don't have to do that. Doctor walks in, takes your blood pressure, and you got a diagnosis. With this, it's a puzzle, and you have to piece it together and say something's evolving. The other thing you're describing to me, in retrospect, is the microvascular disease that we've talked about, the spectrum between veins and arteries. And so I see on one hand patients who develop blood clots, and that's on the venous side. They develop microclotting, sometimes in the legs. They become basically something. I walk in, I see a patient, and they say, well, I get these superficial thrombophlebitis. And that's typical we see with Behcet's on the venous side. And yet you're describing what's on the arterial side, which is the more devastating in terms of the impact when you were describing that you were not speaking proper in your balance issue. These are the very small blood vessels in the brain that feed these very vital organs in the brain. And so what you're witnessing here is this vasculopathy that's occurring. And what's happened in vasculitis, I always tell it's like you have a garden, which is your brain, and you have a hose, which is the water that feeds the garden. And if you start compromising that, parts of it begin to wither and some will die. And so that's what the important part is. When you mention about crossing the blood-brain barrier, you have to choose an effective therapy that's going to go ahead and target that area. You mentioned mycophenolate. It's one of the therapies we have available to us. Again, not approved for Behcet's, but we use it all the time. And so I think tailor-making the treatment to the patient is very important. One thing you didn't mention is steroids, except for topical. And that's the other clue. When you use the topical, you had a great response. And if it was infectious, it wouldn't have responded just to steroids alone. So it's a matter of a series of clues. And I really feel bad for my Behcet's patient because it's all there. It's just the smoking gun is there. Somebody has to put it together.
I understand. Thank you very much.
Thank you, Dr. Suclich, for commenting on all that. And I think at this point, if it's okay, we'll let Beth tell a little bit about her story now.
Hi, thank you everybody for having me today. So my journey is what I would call the long and winding road. I noticed that something wasn't quite right when I was a little girl. I would have joint pain, fatigue, headaches, but they wouldn't last very long. And I'm the youngest of 6 kids. So I always thought, okay, I'm just the sickly child in the family. As I got into my teenage years, I kept getting throat infections, fevers, just sicker than somebody normally would be. And I just thought, okay, maybe I'm unlucky. I got into my early 20s and I had fever, headache, a lot of stomach discomfort, but I always just thought maybe I'm not eating properly, I'm not drinking enough water. And I would say by my late 20s, I knew something was wrong, but I didn't know what. I thought, okay, I probably have really bad allergies because I just feel so miserable. I started going to doctors, and of course, I'm young, I look normal, and they're like, you're probably tired, you're probably not exercising enough, not doing enough. So I just kept going from doctor to doctor, going, okay, I just don't feel well. I don't feel right. And as women, unfortunately, I think we have a harder time being diagnosed because we're women. And they tend to look at you and think, I think you're okay. I had moved from Illinois to Texas, and that's when my disease progressed pretty rapidly. And I kept, trying to seek different specialists. And a rheumatologist said to me, have you had your eyes checked? And I said, no, why would I? And he goes, it's really rare. It's probably 1 in a million that you're going to find anything. Why don't you go get your eyes examined? Lo and behold, I did. And they found uveitis in my eyes. So I had no idea what that meant. I had no idea what that could possibly be. And my eye specialist said, let's treat this with eye drops. And if it gets better, we're going to have to wait and see. But if it continues and goes on, you're going to have to look deeper. It took off like a spitfire. It was out of control. I developed glaucoma, uveitis, cataracts very, very quickly. And I was sent to different specialists. And I also went back to my rheumatologist and said, oh my gosh, this is going on. He said, okay, let's keep tracking symptoms. Well, I did my own research and I found Behcet's, and I'm like, okay, this sounds a lot like what I've gone through. My ophthalmologist finally diagnosed me. And I also have the gene, the HLB51 gene. There was also other criteria that they looked at, and they put all the pieces together. So a very, very long journey finally came to fruition. I have what is called refractory Behcet's. I've probably done every medication that you've offered a patient. They either work well for a little while, but then they become ineffective. So my journey has been pretty heavy. I was also diagnosed this week, like 2 days ago, with an IG deficiency. So my body is not making enough IG. So I will start IVIG therapy again. So that's a critical component for my journey is how do I take medication, stay infection free, and fight the disease. So currently my disease is 100% not in remission. It's been a pretty hard year for me. I will start IVIG again pretty soon. My eyes are somewhat steady. I do have a shunt in my left eye to prevent blindness. And I've had multiple surgeries, and my cataracts are progressed enough that I can have surgery, but I think we want to wait until I'm in a healthier state. And it just led me in my journey when I was, in my 30s thinking, I've got to do something to help people down the road, not be in the position that I'm in. And I connected with Alan Strom, and I started moderating Facebook forums. I branched out on my own, and over the past 6 years, I now have the largest Behcet's forum in the world. So I took something that was a hardship, and I'm making it out to be, how can I be a hero or a champion to other people to help their journey?
Gosh, thank you, Beth, so much for telling us about your journey with Behcet's. Doctors, Suclich, do you want to comment on Beth's situation?
Well, the situation when you were evolving, again, it's when you first started leaving from Illinois to Texas, when you got the uveitis, there's certain Behcet's patients can get the full spectrum uveitis. They can get anterior, the intermediate, and posterior, okay? The most dreaded one is the posterior one. I suspect that's what you had because those patients don't always have the eye symptoms overtly. And those are...
I have the anterior part of it. It was so severe that I do have scarring from it.
So once you have scarring, we're trying to prevent that. And so we're obviously going to use medications that we borrow from other diseases in an effort to treat them. I think a younger patient, like you said, you got it as a much younger age. The problem is just trying to convince younger patients to take medicine. So you got me, because typically with both Alan and Beth, the degree of severity, it's going to require multiple medications and possibly even steroids, which are a medication of itself, which you haven't talked about. So the problem is you're going to a doctor and saying, oh gosh, do I take all these medications? They have all these side effects and all the other problems associated with it. Sometimes we need to use aggressive therapy early. The challenge is if it relapses, how do we know our medications are making doing something and helping you versus the natural course of your disease? Now, the difference is, again, I think with Alan and yourself is you've had fairly established disease. So you're not going to be relapsing and remitting on me too much. So you're going to be on therapy probably for the rest of your life. And that's hard to really, especially for a younger person, to kind of accept that. So part of my problem is when I deal with some of my younger patients is that they treat their symptoms, they get better, they come back, they get better. They relapse themselves because they're not taking their meds. And so that's a challenge for me in trying to help them to understand that this is kind of a lifelong commitment. And the therapies are getting better. We need targeted therapies. That's the second thing. You mentioned that some of your therapies didn't work, possibly because some of them may have been biologics. Some of the biologic therapies, we know your own immune system can make antibodies against them. And so they become ineffective after a while. So we have to understand it, or the disease may get worse. So there's that balance aspect about it, is especially if I'm dealing with, like yourself, if you're a younger woman that's considering pregnancy, I've got to consider that as well. And there's some of the drugs we can't give in situations like this. So there are many different nuances that we have to think about. But I say keep my eye on the sentinel area, the important area. Alan, it was neurogenic. Yours was eye. And if those are very fragile organs, so I figured that's when we are at least more aggressive in our treatment. And you did mention you were seeing a rheumatologist. So they were kind of watching you evolve too. So that's, I think, is important, that any new symptoms that need to be addressed and not minimized.
Thank you, Dr. Suclich, for responding to Beth. I think if it's okay at this point, we have some questions from other patients, and I think we'll cover some of those and see if you can help patients that are not on our webinar today. And I think the first one is there a difference on average in how men and women do with Behcet's and their outcomes? And if so, why is that?
So we figure that when we look at the chromosomal issue about men and women, I don't think it's because women are necessarily have an extra X chromosome or because they have estrogen. It's not like a lupus model that we see. I think it's more related to the genetics outside of that gender aspect of it too as well. I think we're trained to look at typically the severest cases, which are males, typically less than 25, usually come from the Middle East, either Iran or Turkey. Those are the phenotypes that we say, oh, these are the worst patients. And as Alan mentioned before, you said you're too white. See, the problem is they don't count that we don't do a gene assessment on you and say, unless it's an HLA-B51, we really don't do particularly gene modeling to say you're at risk for developing this disease based on your genetic pattern. We haven't gotten there yet. We're hoping that those will be predictive markers probably in the next 10 years that we can say, oh, you're going to develop this down the road. So the differences in men and women, it can be tricky because I think it's more related to not so much the gender, but more the race. So for instance, in my Japanese and my Korean patients, I see a lot more GI involvement. They have the more inflammatory disease. Where I see more in the Middle East, I see more CNS, like the Israeli, the Turkish type of strain, I see that. So it's not so much I feel that it's a gender issue as much I think it has to do more when we look at race, and when that ultimately translates to genes outside the X chromosome.
Well, thanks for that answer. I have another question that is from a male patient. He says, I'm a male with Behcet's and I have a lot of testicular pain. Is this a common symptom, and what therapies can be done to alleviate it?
Well, if you've been diagnosed with Behcet's and you are not developing, for instance, scrotal ulcers, because they can present themselves. What Alan talked about is urinary retention. I didn't answer your question, but I remember it about regarding urgency. Remember, the meatus and the urethra are mucosally lined. And so it's potential. I've not seen yet on cystoscopy whether the patient has developed ulcers. I've not seen that yet. But it's quite, I've seen ulcers develop in males, or, in the penis. So I've seen that. So it potentially can line the urethra, which is that tube that goes, from the bladder. So there's a possibility. So you have to be examined first. If it's testicular pain, one of the things we have to think about is it a vasculitis or a vasculopathy? Because we have to think of the testicular artery and vein. So in that particular case, if it's painful, it requires an ultrasound to be able to detect, is there any evidence of inflammation that's occurring at that site? Because that is an arterial site. And it's also a venous site where it can develop problems. So that should be evaluated. And finally, remember, Behcet's people are normal people. They develop all the different problems that we see in everyday life. You're not immune to anything. So I always have to look back and say, did you get your mammograms? Did you have a genital examination? Did you have a pelvic exam? All these things are so important, especially with the drugs that we have you on. They can cause certain problems. Did you get your bone density? So in a way, I'm always looking not only to see what's going on with the Behcet's patient, but also make sure they say you are normal people. You've got the same normal problems. I'm sorry about that. We still have to be vigilant for that area. So it's good to see your primary care, get a urologist, and most likely you will need an ultrasound.
So again, stay in touch with your physician and do what they tell you to do.
If they tell you the wrong thing, you've got to seek out the right answer. So they need you need an answer, okay? And if a doctor says I don't know, there's nothing wrong with going to a specialist. But I think that genital pain needs to be evaluated. It's not something that people make up.
Great information. And actually, speaking about pain in Behcet's patients, another question came in that said it seems that many patients with Behcet's suffer from exceptional pain. Should I have a neurologist on my doctor team to address the pain management therapies?
The question always asked about pain is it a structural problem or an amplification problem? Structural mean mouth ulcers. You walk in, you have everyone's had a painful mouth ulcer once in their life. Imagine patients getting this over and genital ulcers. So there's the structural component of the pain. But what I found with Behcet's patient also, especially if they have neural Behcet's, when you have these inflammatory cytokines, they do cross the blood-brain barrier. And we see that there's a pain amplification that occurs with this phenomenon. It's not readily recognized, but I've seen people with chronic inflammatory states that this happens. And so what may be a discomfort to you may be exceptionally painful to the patient. And they're looked upon kind of like, well, you don't hurt that much. Well, they're using a scale that's really not appropriate. So I've seen pain amplification as a result of the inflammatory cascade that happens with patients. The other aspect of pain, of course, obviously, is what about the external or outside the body factors? The sleep deprivation is terrible. Okay, I've seen a lot of sleep deprivation in our country. And, having seen that, disrupted sleep is associated with higher pain scores. So we see that as an aspect of it. And that's minimized, and we can't check labs for that. That's the problem. There's no blood test to monitor sleep. So we see that. Depression. I mean, who wouldn't be depressed if they're having ulcers and no one can figure it out and they're being stigmatized, especially if you're in an Alan situation or a Beth situation, you're looking at no one can figure things out. There's the element of depression, which also heightens pain. So there are many psychosocial aspects of it. There are many physiological aspects, and there, of course, the direct effect of Behcet's on the body. So you have to address all those issues. So when you see a neurologist, they have to take all that in consideration. They just can't say, oh, I see you have a painful lesion. Here's some pain medicines. I'll see you tomorrow.
Interesting, all the extra points that you're bringing up that we've never thought about. Thank you for that. I had another interesting question from a patient. I know that mouth ulcers are a frequent issue with patients, but I've also had a huge amount of dental issues like tooth loss, gum disease. Can Behcet's also cause dental issues beyond the ulcers?
It does, and the treatments that we do as well. So the problem with the mouth ulcers is, can you imagine trying to brush your teeth with painful mouth ulcers? I mean, it's a nightmare to do flossing and things like that. So there's an issue of dental care. These patients sometimes can't even eat. So there's an issue with regards to the dental care directly related to, because if you have mouth ulcers. The second problem I see with patients is some of the drugs that we use, corticosteroids, locally, even locally, are problematic because we use steroids obviously to quell the ulcers, and they can contribute to gingival decay and dental decay as well. That's a problem. Then there's systemic therapies that we give that may cause problems with dentition and gingiva as well. So we have systemic therapies and so forth. So all of these factors we have to take in consideration, that the proper dental care and the treatments that we give are very important in terms of measuring and monitoring this as well. So that's what's important. Sorry. So again, it's the dental care is very, very exceptionally important. I usually work with an ENT or oral surgeon in order to help me because of the manifestations of the secondary problems with dentition. And of course, don't forget, when we get a certain age, we worry about metabolic bone disease. And of course, if there's dental caries or problems with dentition itself, we have to think about osteoporosis and metabolic bone disease a lot of times driven by the drugs that we use, the steroids that we do. And that's a problem. And in the United States, and I'm sure there's also tremendous vitamin D deficiency. So there's all kinds of different things that you have to keep in mind when you're looking at oral hygiene.
Well, great. Thanks for answering that so much in depth. I have another question from a patient about COVID, basically. How has the COVID pandemic affected your practice of treating patients with Behcet's? I have the vaccine, but I'm worried that I won't produce enough antibodies due to my medications.
Correct. There's certain medications that we know of that will depress your antibody response. There are many unanswered questions about COVID because we can't measure the amount of antibody present in your body commercially. That's the key thing. In your case, I believe, Beth, you mentioned that you had an IgG deficiency. Is that correct? So obviously what's happening, either as a result of medications or another problem, we're having antibody suppression. So the questions I always have to the immunologist is to say, okay, how much antibodies do I need to fight off an infection? Number one, we don't know directly the answer. We think more is better, okay, but we can't always quantify that. Number two, it's a risk versus benefit assessment. If I stop my medication and in the hopes that I'm going to get a vaccine, is it potential that I can flare my disease, which I then have to use steroids, which is another one of these drugs that do depress antibodies. So we know that certain drugs are definitely associated with depressing antibodies, especially prednisone above 10 milligrams per day. So you have to kind of think about what's my risk of stopping and flaring versus, which I then have to use steroids, which are then bad, or basically taking the vaccine itself. So the answer to that question, no one really knows. I think that what I would do is go for the vaccines that offer the best antibody response. Some doctors are stopping them. I am not stopping my patients off their medicines because they flare. So it makes no sense for my patient to be miserable for 2 weeks waiting for their vaccine. And I don't even have good data if that's going to make a difference. So the recommendation is usually to stop, if you're depending on what drug that you're using, to stop it for a certain period of time. I don't do that personally because I don't want to flare their disease. Number one. Number two is the vaccine safe to take? That's an interesting question, because even though we're promoting vaccination use, and I believe it's an individual decision, I feel very bad when the governments decide to say all people should be vaccinated, because the problem is this. We have had cases of patients, particularly with uveitis, and I've seen this with my ophthalmology colleagues, when they did get the vaccine, they flared their disease, and I did not hold their medicine. So I think it's a very individual decision. I think if you're comfortable getting the vaccine and you're very stable, that's one thing. But I do have patients that flared. So I'm not advocating not taking the vaccine, but I don't believe in whole scale, just everyone needs to take the vaccine, because there are these individual patients who may flare from this. And that is another problem that we face in medicine. Now, I can't look at you and say, you're going to flare and you're not going to flare. So I always look at a patient individually and say, okay, what's your risk of getting the infection? What's your household like? Where do you go to work? What do you do? If you're at very high risk of getting an infection, then you may take the risk of getting the vaccine. But if you're very low risk, and you've had serious disease, I'm not going to push the vaccine on you simply because there's a concern about potential flare. And that's a very individual decision. That's my opinion. I mean, there are doctors who will say, take the vaccine no matter what. So again, but that has not been proven in terms of, at least our FDA has not mandated that this is an FDA approved treatment. So again, we're still in that gray area.
Thanks so much for a very complicated answer. Alan, did you have a question? You could unmute yourself.
If it's okay for me to add to that as a patient, from a patient perspective.
Sure.
So I had the conversation with my specialist about whether or not I should have a vaccine against COVID. And the answer was basically, it comes down to the personal choice of safety. And my choice is to be safe. I want to be protected from COVID. So what was the vaccine going to do for me? And our key concern was, would it make me lose remission, for example, by overstimulating my immune system? I didn't want to think too much about it because that would have hurt my head. So I just simply decided to move forward, have the vaccine, and I ended up having a response, an immune response that lasted about 5 days and then just nicely went away of its own accord. From my perspective, I feel I've had an immune response to the vaccine.
Well, thanks, Alan. It's always good to hear the patient viewpoint as well. And thank you, Dr. Suclich, for that very in-depth answer to a big question a lot of patients have. But I have a question that didn't specifically come from patients, but that we would like to know. If you would tell us what you would consider the most important research or medical breakthroughs in the treatment of Behcet's over like the last decade. Have you seen any studies or potential therapies that are on the horizon?
So there are some therapies that are being pursued locally for mouth ulcers. And since I do some of the clinical trials, I can't get into detail about it, but we're trying to look at Behcet's not only as the systemic disease that it is, but the local manifestations, because we know that we use systemic drugs. Sometimes they have systemic side effects. So right now, there's only one approved drug by the FDA here in this country, and that's only for mouth ulcers. And I mentioned that's apremilast. In the horizon, in terms of looking at it, unfortunately, Behcet's becomes an orphan disease because from an investment point of view, from pharmaceutical industry and the government, they figure, well, this is not as common as, let's say, lupus is or rheumatoid arthritis. So we're constantly borrowing these drugs and applying them to the use of Behcet's as well. I think the more targeted the therapy is, the better, because assuming that it does the job it does. In Alan's situation, you have to use a drug that crosses the blood-brain barrier. So I may not have the advantage of using a targeted therapy in that situation. But in general, when we're looking at now between the biologics and the kind of advanced small molecules, as soon as these drugs become more, say, affordable, especially when you're talking about oral small molecules, you'll be seeing conducting Behcet's trials. The problem is the trials to do that, because I was in a Behcet's trial, so I've done this before. You have to take a homogeneous group of people and then put them on drug A and the placebo. How do you get homogeneous groups of Behcet's patients? You've seen Alan and Beth's disease are completely different. How do you enroll them in a clinical trial? It's very difficult to do that. The only thing you can do is you go for the low-hanging fruit. You say, we'll go after the mouth and genital ulcers because that's what people share, but we're going to exclude the ones with the most severe disease. So Alan and Beth, you would have been excluded from a clinical trial. So there's the problem. The problem is how we go ahead and in the approval in the circuit, we have to have a trial to be able to do this. It's very hard to do, especially in this country, very expensive to do, very risky to do, okay? So we don't have any major trials that we're looking at. However, we are looking at, mouth ulcers, and we are looking at borrowing these other drugs and applying to Behcet's. And so that's coming, but they're going to be small groups of patients. They're not going to be the large trials that you see that the commercials are given on at least on our TV by the various different drug manufacturers, because again, there is a risk of doing this, and there is also, of course, trying to orchestrate a trial to be able to prove whether the drug works or not.
Well, thank you for answering that question anyway. I think it's good for us to know where we stand. I do have one more question. I think this could be more of a question for Beth and Alan, if either of you would like to comment on it also, though. This person says, I'm a 28-year-old woman diagnosed with Behcet's a year ago. One of the biggest issues has been dealing with genital ulcers and skin issues that come with the disease. I'm single, and the thought of dating with these issues seems out of the question. Can you advise on what I can do to have a social dating life?
If it's okay, I'd like to comment.
Go right ahead.
I was back in the dating scene again in my 40s, and it's a fear for all of us with Behcet's. How are people going to react? Are they going to look at us and think, oh my gosh? A lot of people wonder, is this an STD if you have issues? And the answer is no. And I would tell any man or woman, disclose, but slowly and only if you need to, meaning, you have to kind of get your feelers out there, establish a bond, and then kind of go from there. But I think, slow and steady wins the race, but I think it's appropriate to have an honest conversation. If it's somebody that you're going to be intimate with, good rule of thumb, if you're going to lay down in a bed with somebody, you should be able to ask and talk about anything that goes along with that. So I think it's getting to know somebody, getting comfortable with them, and having open dialogue. I think honesty is the best policy, but reassuring them it's not an STD, it's nothing that you can catch, and there's maybe times that you can't be intimate. There may be times that you're going to have to wait, and, that's just part of the process.
Thanks, Beth, for a very personal, but super important answer. Alan, I was just thinking that with your background in education and HIV AIDS information, that maybe you had a pretty good opinion on this also. If you want to unmute yourself, you could answer us.
Absolutely. Thank you, Kathy. And yes, I totally agree with everything that Beth has had to say there. The same thing did happen in my working career in helping people come to terms with their sexuality, but how to express their sexuality safely in a way that they wouldn't be rejected. And it's always the fear of rejection that I found that people were dealing with. And there are two pathways that you can take with this in some ways. One is, what sort of a person are you? Are you the sort of person who just wants to hook up for a brief encounter? And if that's the case, and you're feeling healthy enough to do so, do you need to tell somebody anything that's taking place? Is it their business? The answer may very well be no. On the flip side is, if you're thinking of developing a relationship with somebody, maybe it's important to allow time to get to know someone, find a safe period of time, say after 2 weeks that you choose, or 3 weeks, when you will open up to them about what's going on with you and your body, and then give them time to adjust and adapt and move forward in getting to know you as, the person that you are, who, by the way, just happens to have this illness. The illness doesn't have to define who we are, particularly when it comes to our friends, family, sexual encounters, all that sort of thing. The one thing that I did want to add to all of this is take away the single aspect of being on the dating scene. What about being married and suddenly you've got these genital ulcers that come out of nowhere that sort of make your partner think, what are you up to? And that can add to a little bit of distrust in the relationship. So just be aware that by the time you get your diagnosis, your partner might very well be incredibly relieved to know that it is actually about a disease that can have a diagnosis attached to it, as opposed to a sexually transmissible infection.
Alan, thank you so much for that information and reminding us about married life as well. And Dr. Suclich, I'd love to know if you have anything to add to that.
I do. It's a very sensitive issue, especially if the genital ulcers present from the mouth ulcers. So my take on this is, when I sit down with a patient, genital ulcers and oral ulcers are like any other organ, and they can lead to damage and scarring. And so I say, if you have the frequency of these are being so problematic that you're using topicals on a regular basis, it may be time to use systemic therapies. And that's really where sometimes there's a little pushback, because many of my patients, particularly my younger patients, don't want to take systemic therapies. They'd rather use the local applications. So I say to them, look, treat this like any other organ in the skin, whether it was psoriasis. I treat people with psoriasis in the genitalia. It's the same thing. If it becomes such a stumbling block in your relationship, then it may be time to use this for systemic therapy, but then you got to be committed to the therapy. And there's where you have this discussion of risk versus benefit, whatever systemic therapy you choose, because I'm all for remission. And so that's where my goal. The problem is that the systemic therapies I choose are applicable to what's going on with the patient. I am not going to use a sledgehammer where I don't need one. And so clearly we don't want to overtreat our patients either. But it's the issue at hand is that discussion is an individual discussion with the doctor. And I do bring it up because sometimes patients are a little bit alarmed not to talk about it.
Well, thank you. I'm glad you bring it up. And I think we had very honest answers from Beth and Alan both on it. And I think with that, I'd like to say thank you to all of you for sharing so much of what you shared, your personal stories, for Alan and for Beth and Dr. Suclich, so much information for us today. In addition to that, I need to thank our sponsors. I'd like to thank Chemocentrics, Genentech, and Amgen for their support of our Road to Wellness webinars. They're helping the Vasculitis Foundation provide these valuable educational webinars, and they support our commitment to patient education. And this year, watch for more disease-specific webinars.